Good evening, everyone.
Hello, sir. Good evening.
Good evening, all. This is Chandra Mohan, physiotherapist from Dindivanam Sri Samraj Physiotherapy Center. A warm welcome to all the participants for ExRxIndia's Assessment and Biomechanics of Food webinar. This webinar is live on our YouTube channel, Fitness and Rehab India 2. Those who are watching through our YouTube channel, kindly post your queries or doubts in the comment box. We will read it in our Zoom meeting and our resource person will be answering to it. After the end of question and answer session, we will be sharing the link to download your certificates. The link will be open for an hour only. There will be 5 MCQs asked and you have to give all the 5 answers correctly to download your certificate. Today's topic's resource person is an experienced clinician and also a good lecturer. Presently, he is working in a renowned private hospital in Chennai, and this webinar topic has got cancelled twice already due to his busy schedule. At last, we are here today, and I thank our resource person, Dr. Selvin James, for taking time out and making this webinar happen. I welcome Dr. Rupesh and Professor Duna for their support. And now I welcome our resource person, Dr. Selvin James. Dr. Selvin James,
Yes,
please
sir.
come.
Thank you so much for that nice introduction, sir. It was actually cancelled thrice, I guess.
Yes.
Yeah, I'm very sorry for that. It was
Yes.
because of some issues and it was about to cancel even today, but yeah, luckily we have it here. So I would like to thank the entire ExRx team for giving me an opportunity again. So we would be talking today about the assessments and biomechanics of food. Dr. Chandru has very clearly told me to end up this session in not more than 45 minutes. But yeah, this is a huge topic where we need to patiently understand this. But I'll try as much as possible to complete it. If I'm not able to complete, please kindly excuse me. Let's move on to the topic. When we were discussing about this topic, Dr. Chandramohan was asking me, should I put up the topic as assessments and biomechanics of ankle and foot, or should it be only foot? And it was me who told him to do this, to put only foot. But fortunately, we cannot exclude ankle from foot. It is included, but purposefully I've kept this topic as assessment of foot. Why foot? There are very less number of joints in our body where we call it as complex. For example, your shoulder complex, your knee, your hip, and then your foot. No other joints, as far as I know or I believe, is being called as complex. These are very few joints which are being called as complex, not because they're hard to assess, not because they are so tricky, or not because they are huge. It is because of the biomechanics which they have inside it. Biomechanics in these joints are so beautifully explained in our theory books, in the books we come across. But unfortunately, most of us do not take our time to understand this. This is why whenever I talk to someone, whenever I talk to a physiotherapy colleague, I always tell this statement: to be a skillful physiotherapist, we need to understand biomechanics and learn anatomy. Learning is different from understanding. I repeat the statement: we will have to learn anatomy and understand biomechanics. Foot complex is also one such thing where we just have to understand the anatomy and the small tricky biomechanics in that. If we understand this, then assessment is very, very simple in this. Today I have chose this topic because it's not because that foot is just a complex. your foot is considered to be one of the most important segment which gets affected, or it gets dysfunctioned, or it gets delayed in treating for not only foot or injuries of foot or any small uh, dysfunctions of foot. For example, if you take a cervical joint pain, or so-called as spondylitis or spondylosis or whatever you name it, or a shoulder complex pain, anything you name it, or for a backache, or for a gluteal muscle weakness, or even for a lower cross syndrome, your foot could be involved, or your foot could be the base or the primary uh, complex or the primary involved joint. Foot is so important. For suppose, for an example, if somebody has a backache or if somebody has a lower cost syndrome, you will also have to assess the foot, because foot is so important. It's because of the biomechanics which is hidden behind that, and the connections which the foot has with all the other organs and all the other joints. That is what we're going to understand and discuss today. I'm not going to teach anything new. I'm just going to discuss what we have just come across in all these years as a student. Okay. To give a small introduction about what the foot is, the ankle and foot complex is structurally analogous to the wrist and hand complex of the upper extremity, but has a number of distinct differences to optimize its primary role to bear weight. This last sentence is so important, where we just have to understand it's more or less like a wrist complex, wrist joint, but it has got a very distinct function where it bears weight. Bearing weight is so important in a human life. Whenever we stand, walk, run, jog, jump, or do any activity, your feet is involved. This is why I keep telling, I'll be telling whole through the session that feet is so important, because you bear weight in all these activities. All these activities. The ankle, foot, and toes consist of 34 complex joints. Again, I repeat, the complex does not mean that it's complicated. It has got too many things in it. We just have to understand that. It means that. So do not get confused with the word complex. It just means that it has got too many things in it. It's just like a shopping complex. We just have to segregate. We'll have to divide it into small components, and then we'll have to understand it. So complex does not mean it's complicated. All right. So it has got 34 joints in that. Bony structures, ligament attachments, muscles, contractions can change a single step from flexible structures conforming to irregularities of the ground to rigid weight-bearing structures. This sentence just says the attachments, all the soft tissues, the ligaments, capsules, muscles, fascia, everything can change a rigid structure to flexible structure, or a flexible structure to the rigid structure of your foot and ankle complex. So all the soft tissues are also primarily important as much as your joints, as much as the bones. That's what this says. The flexible rigid characteristic of ankle foot complex provide multiple functions. These are the functions we every day we come across, but we really don't understand, or we are not aware of this. It's suppose the superincumbent weight, however or how much ever the weight is of a human being. Somebody can be 50 kilos, somebody can be 120 kilos, somebody can be 80, 70, whatever. Irrespective of, your foot has to take 75% of the total body's weight, at least 70 to 80%. Next one is it controls and stabilization of the leg on the planted foot. When you stand, when you run, when you walk, when you jump, it has to control your movement. It has to be a coordinated movement, and it has to stabilize. If you are trying to jump from a 2 feet high, the landing should be perfect. It should be a controlled movement, and it has to be stabilized. If it's not stabilized, then you're going to land in the wrong position, which is going to damage your ankle or your feet. You're going to get strained, or you might even get a fracture. So this is being taken care of the foot. Adjustment to irregular surfaces. We all understand this. If this is a very smooth surface, if it's a surface like an ice skiing, or if it's a very rough surface like the one on the roadsides. So our foot has to accommodate, or it has to adjust, or it has to accompany with all these structures or all these surfaces. Unless or until your foot is good, you cannot do this. Most of us would have come across this when we were young, or when even recently, when somebody has a wound, or somebody has a strain, somebody has a soft tissue injury. When you cannot bear weight on a particular foot, you will understand that you're not able to walk properly on irregular surfaces, or even on a smooth uh, surface like an ice or a very soft surface. This is because of the structures of the foot. We're going to see that in the later slides. Elevation of the body, as in standing on toes, climbing or jumping. This is all been taken care of your foot. Shock absorption in walking, running, landing from a jump, operations of machine tools. We all know this. We do this in our everyday routine activity. We do walking, running, jumping. We do keep all doing this. So whenever we jump, whenever we walk, whenever we run or climb, there should be a shock absorbing position, a shock absorbent movement happening in your foot that is being taken care thoroughly by the soft tissues which is attached to the number of joints in your foot. So we will see a little detail in that in the later slides. The substitution for hand function in persons with upper extremity amputations or muscle paralysis. This is in a rare conditions where people do not have their upper extremity. They substitute, or they use the help of the lower limbs, the feet. People who are, I have seen CP kids who use their feet to write, paint. Some people use their feet even to eat. So it's just an additional work where very less number of people do it. So this is a beautiful statement I just came across. I thought I could share with you people. The human foot is a masterpiece of engineering and a work of art. This is being told by Leonardo da Vinci. I don't know why did he tell this and in what situation he told us. This is exactly the apt statement for a physiotherapist to understand. The human foot is really a masterpiece. I'll tell you why this is a masterpiece in the later slides. When you come across the joint attachments and the soft tissues, you will know why the foot is a masterpiece created by God. So we're going to look into the anatomy, which most of us thoroughly know about the joints, ligaments, muscles, and I've specified the joints in, I've highlighted in red color. It's because I'll tell you how many joints we have in the foot. And then comes the biomechanics, which we are going to deal with today. Biomechanics basically means orthokinematics and osteokinematics, meaning the movement inside the joint and movements in between the bones, one and the other bone. So if we understand these two statements, if we understand what an orthokinematic movement and an osteokinematic movement is, then we are the master. We are the best physiotherapist. It's easy to identify in other joints. For example, in a knee joint or a shoulder joint and a hip joint, this is very easy to understand. But foot is also comparatively easy to understand, but it takes a little extra time because it is a combination or a complex of too many joints over there. This is what we're going to understand today. Okay, here is what we're going to understand. We're going to come across throughout this session. Here are the joints and its components or its contents, what we're going to learn today. The ankle joint, subtalar, transverse dorsal, tarsometal joint, and metatarsophalangeal, interphalangeal joints. Then comes the very important structure, the plantar arches, muscles of the ankle and foot, the intrinsic musculature, posterior compartment, lateral, anterior compartments of the muscles, intrinsic musculature, and then comes the deviations, the normal and abnormal structures or the functions of a foot. So here, I'm not going to explain everything because all of us would have come across all these things. we would have read in an anatomy, we would have come across in our biomechanics books. But what I'm going to do is we are going to discuss about only very few joints and part of your arches. Then how do we assess a foot or a dysfunction of a foot or any uh, complex or any dysfunctions of a foot or any injuries of foot. Okay. Okay, here comes the functions of ankle and foot. So as we saw in the previous slide, the stability, mobility, and the most important is protection. We all understand that the foot complex provides a stable base of support in variety of weight-bearing postures. Suppose we stand in a single leg stance. Suppose we jog, we run, we jump, or we try to climb stairs. We have to be stable. If we don't walk properly, or if you don't share the weight, instead of using walking, I could put up this statement: if we don't share the weight equally, or eventually we tend to fall. This is what happens to people or females who use a high heel. The weight sharing, the weight loading is not equal, or it's not equally spread. I'll show you in a picture later on how is it equally shared. And the stability acts as a rigid lever for effective push off during gait. This foot is the very, very, very beautiful complex and one of my favorite joint to treat. I treat a lot of sports injuries and people with orthopedic issues in the foot and ankle. It is because for any movement in a human being to happen, you need the foot to be stable, or you need it to be rigid, or you need it to be so mobile. If you want to walk, if you want to start running, if you want to do a sports activity, I guess Rupesh would be even more he would understand, or he would be the best person to explain about sports injuries, because he's into a lot of sports people and sports injuries. So any movement to happen, you need your foot to be stable. You need your foot to be giving equal or sharing equal amount of weight. If you give a good push off, if you give a good start with your foot, then your movement is complete and successful. If your movement in the foot and ankle is not good, if it does not have a good start, then your movement is unsuccessful. You land up in some or the other injury. Then comes the mobility. It absorbs stress and shock, pliability for off, and propulsion of body in walking. So your foot and ankle are so important for your stability, to be stable, and for moving, running, jumping, walking. It includes everything. And protection. This is so important. This is the most beautiful function of the foot, which I personally like, which has been created by God. Sensation of sole of foot. Imagine people, if some of you or some of us do not have the sensation in your foot, your gait pattern is gone completely. Imagine you have a small injury, or you have a strain, you have a fracture in your foot, any one of your foot, and if you are on a POP or a cast or on some ankle boot, and if you don't touch the floor with your sole of the foot, you lose the sensation, you lose your stability, you lose your mobility, and you don't have balance. You're not able to walk properly. Your gait pattern changes, you lose your muscle strength. It's a series of complex happening. It's a series of dysfunction happening. So sole of your foot is so important. This is why most of our sports physiotherapists, most of the biomechanic physiotherapists keeps telling that children at the young age have to walk in and around the house without footwear. But we see in the recent generations, in the advancement of the technology, we see people, as soon as the child is born, they put on socks, shoes, this, that, and make the children walk with that. And finally, they lose their arches. Arches are so important, and the sensation of your foot is so important for a child to adapt his walking pattern. If this is not happening, then your gait pattern is going to definitely change. You or whoever it is will have some or the other foot dysfunction, ankle dysfunction, which will lead to a series of problems in your knee, hip, SI joint, spine. It goes on like that. Okay. The foot, I guess we all know this, so I don't have to explain this in detail. It's again divided into three divisions: the midfoot, hindfoot, and forefoot. This slide explains about what is involved in your hindfoot, what is inside your midfoot and forefoot. And again, the arches are also divided into three. We know this: the medial and the lateral and the transverse arch. So this is one example of picture. There are a lot of pictures, but I did not want to include because of the shortage of time. This picture tells about how different types of motion happens in different axes. I hope all of you can understand this one picture. See, there are different axes here. You can see the lines over there, the longitudinal axis, coronal axis, and the vertical axis. So based upon these axes, the movements happen. You can see in this, the abduction and adduction happens in the vertical axis. The dorsiflexion, plantar flexion happens in the coronal axis, and the supination and pronation, or the other way is called as the inversion and eversion, happens in the longitudinal axis. So whenever we have a patient with some or the other foot problem, a foot dysfunction, we just have to analyze in which motion or in which direction or in which axis the movement is not happening or the movement is painful. And according to that, we just have to think about what are all the structures involved in that particular motion or in that particular axis. And according to that, we'll have to assess and treat. In a closed pack position of the talocrural joint is full dorsiflexion, and accessory motions are therefore performed in slight plantar flexion. Like all the other joints, foot also has a very important movement pattern happening, the closed pack and the open pack position, which is so important in biomechanics. Whenever you give an exercise, whenever you prescribe an exercise for your patient, you have to think double, twice, even any number of times you can think, and you just have to prescribe the exercise. And you'll have to think what kind of exercise are you going to give for what injury. If it is a fracture, it's a different set of exercise. If it's a soft tissue injury, then you're going to give a different set of exercise. If it is a post-traumatic stiffness, then it's a different type of exercise. You cannot prescribe the same exercise for all of these injuries. So a closed pack position of the talocrural joint is complete in dorsiflexion. The accessory motions happens in a slight plantar flexion. With the medial and lateral malleoli stabilized, imagine you're going to hold a joint where you're going to hold the medial and the lateral malleoli. You're going to stabilize in one hand. The talus can be moved passively. The hand which is holding the joint can move the talus passively in posterior or anterior direction and distracted a few millimeters. You can feel, if you comfortably properly hold on to the ankle joint and the talus, you can really move it to few millimeters. 2 or 3 millimeters of motion are considered to be normal. If it is more than that or if it is less than that, then it is into some problem. You just have to assess it. There could be a soft tissue injury, or there could be some other problem with the joint. It could be an osteokinematic, orthokinematic issue. We will have to assess it. So holding the lateral and medial malleoli, if you're able to move passively the talus bone with few millimeters, 2 or 3 millimeters are considered to be normal. If it's moving more than that, then it's going to be a dysfunction. Excessive anterior or posterior movements are called anterior drawer or posterior drawer sign, and these are indicative of ligamentous laxity. So see how easily the assessment can be done. We think foot is so complex because it's got too many joints in it, and we call it foot complex because it's complicated. No, not at all. Foot is very, very, very easy to assess and to understand if we practice it in the proper way. So you just have to move the joint like how we do a manipulation or a mobilization. You try to move it and anteriorly and posteriorly, just try it. If it's so excessively moving, then it's called an anterior or a posterior drawer sign, which indicates a laxity or disruption of a ligament. So this is how you assess a ligament injury or a ligament dysfunction in an ankle joint. So these are few pictures I've put up. There are a lot of pictures which I have of my own patients, but due to time constraint, I have not added it. But if someone wants it, I can really show them. I've done a lot of taping, a lot of manual therapy corrections for a lot of people who have foot and ankle issues. So this is how an abnormal foot would be. When you want to do a complete assessment of a foot and ankle, you actually have to look into the posterior aspect of the foot. You cannot sit in front of the patient and look. Yeah, there are certain conditions where you can see from the anterior aspect also, but it is always good to analyze the patient from behind or from the posterior aspect. So you will have a very clear idea. Like just in this picture, you can see the angulation, the line of normal biomechanical axis, it has been changed. So when you look into a patient, you make them stand in a complete full weight bearing, and you ask the patient to just simply stand, and you see, you can notice a lot of difference in the angulation. With this, you can clearly assess of which joint or which ligament is affected. This is one small technique that you can assess. And what are the muscles involved in it? As we already saw in the first few slides, there are a lot of group of muscles which are involved into the ankle and foot complex, because it is the base. Your foot is the base, and foot is so important for your stability as well as mobility. So most of your lower limb muscles are directly and few are indirectly connected with fascia to your foot. So muscle activity is critical for dynamic stability and integration of movement at multiple joints of foot. No muscle is single joint muscle. This is a very important statement I've taken from a biomechanics book just for our understanding. You just have to think about this. No muscle is single joint muscle. So always in a foot, any muscle you take, it is connected with some or the other joint or some or the other group of muscles. For example, your calf muscles, your gastrocnemius soleus, or your anterior compartment muscles, your tibialis anterior or your tibialis posterior. Your lateral compartment is also like that. So all muscles are into connection with the other joints or other group of muscles. It's never alone. What are the functions which happens there? Dependent on stability of tibiofibular mortise. I'll tell you what the mortise is in the later slides. For mobility role, mortise belongs to primary of the fibula. Mortise is just something behind, in between your malleolus. The shape of talus facilitate ankle stability. So this is also an important statement where we have to take a note of this. The shape of the talus facilitate ankle stability. The shape of the talus is not the same for you and me. It's not the same for one individual to another individual. So the facet structures in the talus joint or the talus bone differs from person to person. The medial facet and the lateral facet differs. So if there is an abnormal attachment, or if the shape of the talus is abnormally small or large, or if there's any trouble in the talus joint, then there's a question mark about the stability of your ankle and foot. So one small bone, one small attachment in your ankle and foot can change the entire stability of your body. You'll not be able to walk normally. You'll not able to, when you cannot walk, you cannot run, jump, or do any activity. So you lose your gait, normal gait pattern, your stability is gone. You do not have a coordinated movement. So trochlea or the wedge shape in weight bearing, during dorsiflexion, tibia rotates over the talus. This is also an important statement where we just have to understand this. Whenever there is a dorsiflexion happening, your tibia slightly rotates on your talus. Imagine if your talus is not good, or the shape of the talus or the facet of the talus is not good. If there's a facetal dysfunction, or if there's a small ligamentous injury over your talus, then when your tibia rotates, the movement is not going to be complete. It's going to be painful, or it's going to be a dysfunction. Wider anterior part wedges into mortise to enhance stability. So your stability of your ankle and foot is being taken care of your talus. Talus is one very important bone which takes care of the stability of your foot and ankle. This allows ankle to withstand compression forces of 450% of your body weight. Imagine if this small talus can take so much of pressure, how important is this? So Whenever you want to assess a problem, assess an injury in your foot, always think about talus primarily, because that is more prone to get injured. So when you start your assessment, start up with your talus. This joint motion is necessary for normal load distribution, cartilage nutrition, lubrication of ankle joint. So all this is involved inside your ankle talus joint. So plantar flexion, this is a loosed packed position of your ankle. This is less stable. Higher incident of ankle sprain happens here. So if somebody says, a patient comes to you and he says, when I was walking, I fell down, I slipped and fell down, or I twisted my ankle, always go look into this loose pack position. Do a plantar flexion and check if there's any instability, or if there's any pain, or if there's any joint range of motion restriction in this particular place in the plantar flexion, which is a loose pack position. This could be an ankle sprain. Forget about which ligament and which soft tissue is injured. It could be an ankle sprain always. So you can do an anterior droit rest or posterior droit rest and check this also. Asymmetric in size and orientation of lateral and medial facets. This is what I've been telling. Of talus, changes ankle mortise during dorsiflexion, causes greater displacement of fibula over lateral malleolus during dorsiflexion. All right. When there is a change in the size or the orientation of your facets in the talus, your talus is just right behind your below your tibia. If the facet joints in your talus is in different shape or the orientation is abnormal, then your dorsiflexion is going to be into trouble, which would in turn create a problem with your rotation or the torsion of your tibia, which is going to put you into a strain, and it will create a lot of pain. Your biomechanics will be changed, your normal biomechanical axis would be changed, and your stability would be a question mark for that. So one small change in your facet could change the entire gait pattern of your foot and ankle. So now we're going to see about, I'm not going, as I said earlier, we're not going to look into all the joints. I'm just going to talk about very few things which I believe is important, or the common sports injuries which happens in the foot and ankle. A subtalar joint, this is highlighted. You can see here the calcaneus and the talar joint. So we're going to look into what happens there. The talocalcaneal, or otherwise called as the subtalar joint, is composite joint formed by three separate plane articulations between the talus superiorly and the calcaneus inferiorly. So this is how the joint is formed. Together, three surfaces provide a triplanar movement around a single joint axis. This is what we will have to understand, and that's why I've put up this sentence here. A single joint axis. We saw in the previous slide, there are three different axes: the longitudinal axis, coronal axis, and the other axis. So here, three different movements are going to happen in a triplanar movement. Three surfaces are there, but only one single joint axis. This is what we as a physiotherapy doctor have to understand. The movement pattern, the movement direction, and the orientation. If we understand that, we can very easily assess a subtalar joint dysfunction or a subtalar joint injury, and we can cure or we can treat the patient. Functions that the weight bearing of subtalar joint is critical for dampening the rotational forces imposed by the body weight while maintaining contact of the foot with supporting surface. This is because this sentence says, when there's a problem, when there's an injury, when there is a dysfunction in your subtalar joint, you cannot bear weight. That is because all the three movements, the triplanar movement, happens in one single joint, and when you start putting weight on your subtalar joint, it's going to be very painful because of the injury or because of the dysfunction. So what are all the important ligaments? There are a lot of ligaments. Ligament is attachment in your foot, and I guess foot is one small organ which has got more number of ligamentous attachments in 1 centimeter cubic. So we're just going to see about very few or most important ligaments we come across which gets injured often. The calcaneofibular ligament, which is attached to the fibula and the calcaneum. The lateral talocalcaneal ligament, cervical ligament. Cervical ligament is one of the strongest ligaments, very important ligament. Some people think that's in the cervical bone, but it's not there. It's in your foot. The intraosseous talocalcaneal ligament, which has anterior and posterior bands. It's got two bands. This is also one of the most important thick band or thick structure of ligament. So here are few pictures which tells about your attachments. Ligamentous attachment. It is given in our own biomechanics book. It's on the Google. You can look into a lot of pictures. I've just put it for example. This picture I've put up just to show how closely and small the ligaments are to connect one bone and the other, because your foot has got very small bones, the talus, calcaneum, cuboid, cuneiform, and your metatarsal bones, your phalanges, all small bones which are closely associated. So these needs a lot of ligamentous attachment to hold them into position or hold them into a normal biomechanical position to create a perfect movement. So that's why I've put up this picture. The foot has, and look at this is a very important statement. The foot has the highest density of ligament tissue per square inch in the body. That's a very important statement. So this is why foot is my favorite joint to deal with or to treat with. It's very easy to assess. We think it's a complex. It's not at all, people. Foot, though it has got lot of ligaments or highest density of ligaments, it's very easy to assess. Having large amount of joints and ligaments, it would be reasonable that this complex is important to the total body function. That is why it's important. Probably God has created in such a way, because whenever we try to do any movement, we need to bear weight, except sitting. Even on sitting, sometimes we put our weight on the foot. So that's why your foot complex has got so many joints and so many ligaments in it. Research shows that ligaments have two functions. This is a recent research. If you want, I can share the article with you sometime later. Ligaments have two functions and can be grouped into two anatomical categories. One is static stabilizers of joint, which we all know. The second one is sensory or proprioceptive function. This is the most important function, which I would believe as than being a stabilizer. Your sensation and proprioception is so important. Imagine when we remove our footwear, when we walk with a bare foot, and if there's no power, even when we walk in a dark moonlight or in a dark room, we are able to identify the things which are on the floor. If it's a smooth floor, or if you're going to touch your footwear, or if you're going to touch the floor mat, or if it's a stone, or if it's a thorn, we can easily identify it. It's because the sensory structure or the sensory function and the proprioceptive function which God has created in the sole of a foot. This is why when you run on a thorn, or when something is hitting you, even if it's dark in the night and something pierces you, you immediately take your foot off from the floor. So the sensory and proprioception function of your foot is amazing. And if this is reduced, your stability will be compromised. This is why people who are on a POP or who has got a fracture, lower limb fracture, who do not bear weight, who are on a single leg weight bearing for quite a while, maybe for 4-6 weeks, if they do not put weight on a particular foot, and after that, it's very hard for people to train them to bear weight. It's because they slowly they've lost, or it is reduced. The sensory and the proprioceptive function is reduced. So it's very important. That's what the recent research has said. This is one of my favorite pictures. I put up this whenever I deal with ankle joint. So you can see there's a lot of ligamentous attachment, and I've numbered it also. There are very few ligaments which we are going to talk about. The ligament with high percentage of collagen fascicles are the static stabilizers, or tensegrity terms, the tension elements. So the ligament takes care of your stabilizers, your foot, your ankle. It gives the complete stability because of your collagen structures. And your ligament has got the researchers, and when you come across people who have come across fascia manipulation, in fascia manipulation, Luigi Stecco, the founder of fascia manipulation, has found in a research, and that paper tells about more than 80% of your sensory receptors are in your ligaments or in the fascia, which is very closely attached to your ligament. And that's why ligaments are so important for your stability. The ligaments with high percentage of water and space are involved in gathering efferent information such as tension, position, and speed of a movement. See what all your ligaments does. We think ligaments are very simple structures, but it has got so many functions in that where we do not seriously take into consideration. The long plantar ligament, that's number 9, which is primarily a tension stabilizer with dense collagen. You can see in picture number 9, this one, the blue structure. This is the long plantar ligament, which is a very important ligament in your arches, in your medial arch. The bifurcating Y ligament, which is in 11, picture number 11, is a receptor-rich sensory ligament informing the CNS about the mid-foot motion and position. Take a look at that. I'm sorry. Take a look at this. Number 11, this yellow color structure. This has got rich sensory fibers. I already told more than 80% of the sensory nerve fibers or sensory neurons are there in your ligament and fascia. And this particular ligament, the bifurcating Y ligament, has got rich sensory receptors where this ligament informs the CNS about the midfoot motion and the position. So people who do not have proper stability or proper balance and coordination, you can treat on this ligament. You can do a fascia manipulation, or you can do some other manipulations to treat the foot. It's so easy to treat a foot. And this is another picture which tells about the deltoid ligaments, which are on the medial side of your foot. This is my favorite picture of the foot. Whenever I talk about foot, I put this picture. So this picture is from a live cadaver, which shows the complete plantar fascia. See, you can see the connections or the orientation of the plantar fascia starting from your toes it gets attached to your calcaneum, which is also a connection of your triceps surae. So whenever there is a tension, whenever there is a pressure overload here in the triceps surae, your medial arch or your plantar fascia can get affected. Whenever there is a twist, whenever there is a pronated injury, your plantar fascia would be disturbed. So you will have to, or we will have to treat this also. It's very important. Here comes the metatarsophalangeal joints. There are 5 metatarsophalangeal joints or condyloid synovial joints. We have come across all this in our biomechanics class. So this is responsible for doing extension, flexion, abduction, and adduction. So these MPT joints, in the rare instance when the foot participates in grasp-like activities, when you're walking barefoot in a beach, or when you want to do any activity, running or jogging, or some of the other activity with a barefoot, your fingers or your toes automatically gets into a grasp-like activity. It holds on to the floor, holds on to the ground. Flexion and extension are predominant functional movements at these joints. So this is why I've put up this joint. So metatarsophalangeal joints are so important for your mobility. When you do an activity on the floor with a bare foot, your toes goes into a grasp-like activity, and predominantly your extension and flexion happens here in this metatarsophalangeal joint. During the late stance phase of walking, toe extension at the MTP joint permits the foot to pass over the toes, whereas the metatarsal heads and the toes help to balance the superimposed body weight through activity of intrinsic and extrinsic toe flexors. See, this statement tells us whenever there is a stance phase happening, the later stance phase, the toes gets into an extension position. Your MTP goes into an extension position, where the metatarsal heads helps to balance. When there is a metatarsal head, those heads will take over the weight of your body. That will balance your body when your toes goes into a extension position during the later stance phase. And during this time, your intrinsic and extrinsic toe flexor muscles act too much. So these are all very small, tricky biomechanics where we will have to understand. During the later stance phase, your toes goes into an extension. When it goes to an extension, the metatarsal heads take over the weight bearing of your body. So it's very easy to understand. When a patient cannot bear weight, when you ask them to raise their toes and bear weight on your heel or on the head of your metatarsal, if the patient says, I'm not able to do, then there's some problem with the metatarsophalangeal joint. You'll just have to treat that, or the ligaments and fascias over there. Here comes the arches. As I already told, we all know about the 3 different arches. We're just going to see about few functions about what arches does here. Although we may think of and refer of the 2 longitudinal and transverse arches as if there are arches which separate, the arches are fully integrated with one another and enhance the dynamic function of the foot. This is very important. The second half of this paragraph or this statement is very important for us to understand. Both the arches are not separate. They work together. They work integrated. So if there is a problem with one arch, there would be definitely problem with the other arch also. This is where we don't understand, or we are unaware of this, and we don't treat the foot properly, which leads to some other complications. If there is a supination injury, or if the patient gets into an eversion injury, if the medial arch is damaged, or if it's dysfunction, or if it's injured, you will always have to check the other lateral arch also. If we do not do that, if we don't do that, then the treatment is not complete. Then the foot is going to get into trouble, maybe today or tomorrow, or maybe after a month or after 6 months, it's going to be get into dysfunction. And that would be a continuation to your posterior aspect of your body. It will continue to your triceps surae. It will get into your calf muscle, hamstrings, hip, SI joint, everywhere it will be contributed. When your foot is not working properly, it would definitely affect the other proximal joints also. The arches are not present at birth. Take a note of that, but evolve with the progression of weight bearing. This is why we ask the young kids, children, to walk with barefoot. But what we usually do is we think that the child gets cold and we put on the socks, winter socks, this, that, foot. We give different types of footwears and we spoil the arches of the foot. And when later on, when the child grows up, when she or she gets a flat foot or a high arch, then he or she gets into trouble. Especially for females, it is directly linked with your pelvic floor muscles, and it's a combination. It's a chain of reaction. Your foot. Females who are here, if suppose females are here, you can understand this. This is another big topic. I'll just give a hint about that. Your arches and your foot plays a very important role in your menstrual cycle, in your pelvic floor stability, in your pelvic floor rehabilitation and pregnancy. It's very important. Females need to understand about your foot, especially because it plays a very important role in your pregnancy. Structure of the arches. The longitudinal arches are anchored posteriorly at the calcaneus and anteriorly at the metatarsal head. This is what I showed in this picture. Your arches are attached from your anterior to the toes to the posterior to the calcaneum. This is what this statement tells about. The longitudinal arch is continuous both medially and laterally throughout the foot, but because the arch is higher medially and the medial side usually is a side for reference. So we think that the medial arch is so important, medial arch is so high and all, but the previous slide what we saw is the arches, the 2 different arches are not separately working. It works integrated, it works together, it works in unison with both. So if one is affected, the other will also be definitely affected. This is what we'll have to understand about these arches. The talus rests on the tops of the wall of the foot and is considered to be the keystone of the arch. This is what we were talking about. If the facet of the talus, if the medial or the lateral facet of the talus is dysfunction, if there's a small problem with the facet joint of the talus, or if there's a small anterior version and posterior pulling of the or talus, which leads to an anterior or posterior drawer sign, then it's going to affect your entire foot. It's going to affect your entire joint. That's what is again told here also. The talus rests on the top of the foot, and it's continued to be the keystone of the arch. For your arches to be good, you will have to consider your talus bone also. So people who have a heel pain, people who say I have a calcaneal spur, people who say I have a plantar fasciitis, you treat them with ultrasound, you treat them with taping, you treat them with needling, you do fascia manipulation, um, you do a kinetic chain activating technique, do whatever you want. But before that, check with your talus also. If it is dysfunction, you'll have to correct it. You'll have to check with the talus and the other associated or closed soft tissues and your ligaments also. All weight transferred from the body to the heel or the forefoot must pass through the talus. Look at that. That's also another important statement. So talus is so important, very important in your arch and your foot. All the weight which comes from your body has to pass through your heel through the talus. So this is a nice picture which tells about how your transverse arches are formed and how is it situated. The shape and arrangement of the bones are partially responsible for stability of the plantar arches. It's just partially. The shape and arrangement of the bones are partially responsible for the stability. So most of the stability is taken care by your ligaments and other soft tissues. What does the arch do? How does it function? The plantar arches are adapted uniquely to serve two constraining mobility and stability weight-bearing functions. Two contrasting mobility and stability weight-bearing functions. So the arches are so important for us to assess during any foot injury because this constitutes both the mobility and stability. If the patient says, I'm not able to walk, then look into the arches, look into the talus, look into the soft tissues around that, look into the ligaments over there. If the patient says, I'm able to walk, but I have a mild pain, or whenever I transfer my weight from left to right or from right to left, I have a pain there, but I'm able to walk, I'm limping, then again, it could be a problem of the arches. Check the arches properly. To accomplish this weight-bearing mobility function, the plantar arches must be flexible enough to allow the foot to dampen the impact of weight-bearing forces, dampen the superimposed rotational motions, and adapt to changes in the supporting surface. So these three have been taken care by your arches. It needs to bear weight for forces. It needs to be superimposed to rotational motions like what we saw on the tibia. Whenever there is a dorsiflexion, plantar flexion, the tibia has to rotate over the talus. If that does not happen, it could be a problem of your arch. And then it has to change its supporting surface. So if these are not done, then it could be a dysfunction of your arch. This is another nice picture which shows the plantar ligament and the plantar fascia. So to accomplish weight bearing stability functions, the arches must allow distribution of weight through the foot for proper weight bearing. So the arches are so important and so very it's very important to take your weight. It carry the weight through and it has to bear weight. If your arches are failed, if your arches are collapsed, then your weight bearing is not going to happen. Conversion of flexible foot to a rigid lever. When you do a movement, when you are, suppose if it's a sports person, when you are about to run, when you're about to throw a ball, when you're about to jump, when you're about to kick, people who are practicing martial arts, when they kick with one leg, the other leg has to support. The other leg has to take over the entire stability of the body. In patients like that, in people like that, your entire stability has to be taken care by your foot. And that is where your flexibility changes from a flexible to rigid lever. So this has been done by the arches. If there's any collapse, if there's any dysfunction in an arch, your entire biomechanics of your foot is being collapsed. And that is where martial art people fail to succeed to do a exact kick. Or people who are trying to throw a ball, who are trying to soccer players, football players, they slip and fall because of the abnormal biomechanics. So arches are so important. The mobility, stability functions of arches of the weight-bearing foot may be examined by looking at the role of the plantar aponeurosis and by looking at the distribution of weight through the foot in different activities. So whenever we do different activities, the arches has to take over the different function. At some point it takes the mobility function, some point it takes the stability function. The passive structure contributes to the arch support. The role of the plantar aponeurosis, or otherwise called as the plantar fascia, is particularly so important. That's why I've put up this picture. The plantar fascia is so important. This cadaver picture tells about or gives an idea about, this is a live cadaver picture, a photograph taken from a cadaver. This clearly tells about how a plantar fascia attachment is. You can see this picture. So that's what this statement also tells. To take a passive structure of the arch, your plantar fascia, or otherwise the plantar aponeurosis, is so important. This picture tells about how the trabecular system and the weight-bearing structure is being transferred. If 100% of weight is being shifted from the body through your leg, 50% of your weight is being transferred to the hind foot and 50% to the forefoot. So this is how your weight has to be equally shared. This is what happens. The weight is not being equally shared for wear. Suppose there are men who do not know how to choose a footwear, how to purchase, how to get a correct footwear of their size. People who wanted to play, people who are getting into new sports, they don't know how to get into how to purchase a new shoe. It's again involved a lot of biomechanics. A physiotherapist who understands biomechanics will help a patient to get into a proper footwear. If you do not wear a proper footwear, the weight bearing structure or the transfers of the weight in this trabecular system is not going to happen. If people, those who wear a high heel, especially females, your heel is being lifted and your forefoot is taking more amount of weight. It's not 50-50. It could be 20-30 or 20-80 or 30-70. In that condition, your arches are getting collapsed or your arches are getting into trouble where your entire biomechanics is abnormally affected. So plantar pressures are much greater during walking than standing, with the highest pressure typically under the metatarsal heads and occurring during a push-off phase of walking, when only forefoot is in contact with the ground and is pushing to accelerate the body forward. See, this statement tells when you're trying to walk or when you're trying to do a movement, when you're starting to run, or when you try to jump, or when you try to move from one place to another, your foot has to be stably on the ground and the pressure is being equally carried at the head of the metatarsals. If that is equally carried, you can give a exact push off, exact takeoff, and the acceleration of the body is equally simultaneously happening. If the weight is not equally shared on the metatarsal head, when you try to push, when you take a takeoff, when you try to start running, then it's going to be into trouble. Your arches are going to get collapsed. Your complex joint or the small joints of your foot is going to get disturbed, and you will not have a proper propulsion. You will not have a forward propulsion. It's going to get into trouble. Then you might land up in some strain. You can have a pain. The greatest stress to the heel during walking occur at the heel strike, and typically 85% to 130% of the body weight is happening during the heel strike. Running with a heel contact pattern increases this force to 220% of the body weight. So eventually when you try to do a walking or running, the position of your foot is so important. When you put your heel, when you land on a heel, the pressure is going to be more. This is very simple to understand. People who are interested in radiology or who have the habit of looking into X-rays, you can look into simple alignment of your body. This picture tells about the normal alignment of your calcaneum. Calcaneal inclination, the angle between the ground and the inferior aspect of the calcaneum. So this would be 20 degree. See, the calcaneal angle from the floor would be 20 degree. So distal calcaneus would be tilted upwards, and horizontal orientation, it will create a pes planus, and when it's tilted upward, it creates a pes cavus. So if you understand, if you are able to look into a radiological image of a patient's foot, you can easily identify what is happening with the arches, and you can do a simple assessment with knowing these biomechanical tricks. This is another picture which tells about the intermetatarsal angle, the IMA angle between the first and the second ray or the second metatarsal. It should be less than 9 degrees. You can just give a rough imaging, or you can just skim over that with an X-ray. If it's more than that, then it's going to be into trouble. This is what mortise is. The distal most aspect of the fibula is called the lateral malleolus. We all know that. Together, the malleolae, along with the supporting ligaments, stabilize the talus underneath the tibia with all these supporting structures. The bony arch formed by tibial plafond and the two malleolae is referred as the ankle mortise. So the ankle mortise is so important for a foot and ankle motion to happen. If this ankle mortise is abnormal, then there's a problem with the foot and ankle. We will have to look into it, or we'll have to correct it, we'll have to treat it properly. So we will have to know what an ankle mortise is and why is it abnormal, how is it abnormal. We can just do an anterior draw sign or a posterior draw sign and see whether the talus is normal or abnormal, or is it dysfunction. This is how the weight is being distributed through the foot. When the foot is in weight bearing, dorsiflexion occurs by the tibia rotation, as we already saw this. The concave tibio-fibula segment slides forward on the trochlear surface of the talus. Whenever there is a weight bearing, the tibio-fibula segment slides forwards over the trochlear surface of the talus. It moves over the talus anteriorly. Wide anterior portion of the talus, the wedges into the mortise. So the talus, the wedge shape of the talus should get into the mortise, or the anterior portion of the talus wedges into the motion. It moves into the mortise, enhancing stability of the ankle joint. So if somebody says I fell from a bike, I met with an accident, have an instability of the ankle or the foot, do a simple assessment of the talus. You can identify whether your foot and ankle is into trouble or not. So we have come to the end of the session. This is one of my usual favorite statements I like. Your symptomatic treatment does not bring you cure. Only expert treatment of cause will yield you success. So if we all have to be a successful, good, skillful therapist, we have to do a detailed assessment. So assessing the foot and ankle is so simple. It is not complex, though it has got the name as foot complex. It's very, very simple. By just assessing the talus, assessing the arches, we can do a lot of magic with the foot dysfunctions and injuries. I have just given an outline of how to assess a foot, and small here biomechanics of here and there, because foot and ankle complex, we need at least 1 or 2 days to entirely cover the portion. This needs a lot of hands-on technique, needs a lot of practical sessions, which is not possible in this virtual media. So if possibly when things gets normal, we can have a live session, a hands-on technique. But as of now, in this shortened time duration, this is what I could share out. I guess I have given very few informations about what an ankle is. People who have questions can shoot out to me. Thank you so much for the session.
Thank you so much for a wonderful session, Dr. Selvin. You have explained how the foot complex works as a shock absorber, and it is very easy to understand the foot biomechanics. It's not difficult. As you said, complex doesn't mean complicated. It is really easy. And the way you explained about the functions, even I am not aware of this third function, which is important, protection.
Okay.
And yeah, we know that stability and mobility, but thanks for enlightening us with the third function, which I was not aware of it. Many maybe. Okay, and yes, you have explained about how weight loading is not shared equally in high heels, and why you have put a diagram how the 50 percentage of weight load share, hind foot and forefoot. And thanks for enlightening many regarding the loss of development of arches in children.
Yes, sir.
How the modern parents make mistakes, and wonderful explanation of axis of motion and the close back position and the importance of anterior and posterior movements, especially the anterior drawer and posterior drawer test, and how much distance it may move front and back, and what it indicates. And thanks for that, and thanks for a wonderful information, especially the shape of talus which facilitates ankle stability, and many more, how it is related to the pelvic floor. You made us to think, and most of us have to search for answers until you are going to take the lesson for the next time. And a wonderful radiograph which gives idea of radiograph picture, which gives that how to find the best cavers and planets. And thank you for a wonderful session. I request our participants, if you have any queries, kindly write in our chat box. Those who are watching in YouTube, you can write in the comment box. We will read here. Participants, kindly take time to raise your questions now.
Thank you so much for the opportunity, sir. People who have questions can shoot it up to me now.
Yes, a few questions are in.
Sir, there are already a few questions.
Oh yeah, I'll look at this.
Yeah, sir. First question is from Miss Archana.
Okay.
Which ligament
is mostly affected
in ankle sprain?
Yeah, I guess Rupesh should be more apt person to explain this, but I'll just tell out my idea. See, we are biased to, usually we physiotherapists, when we come out of the college, we are biased to some, standard pattern of treatment. If it is an osteoarthritis knee, okay, we should give only these exercises. If it's a PA shoulder, we have a set of exercise. No, it's not like that. Please, people, think out of the box. It is not one particular ligament. That is why I've put up one of my favorite picture over there. Foot has got the most number of ligaments, dense ligaments over there. So you cannot assume which ligament gets affected or injured very commonly. It depends upon the mode of injury, depends upon the weight of the person, depends upon what kind of sport is involved into, depends upon the mode of injury. If it is a small, fall, then the type of injury is different, or the ligament which is affected is different. If it's a fracture along with ligament injury, then the mode of injury is entirely different. If it is an inversion injury, then the ligament is different. If it is a pronation injury, then it's different. Okay, so the mode of injury, type of injury, and the type of dysfunction happening is entirely different. So you cannot name one particular ligament which gets usually affected. See, there's one ligament in your shoulder, the acromioclavicular ligament, which is another strongest ligament. When you do a push-up or when you do a pull-up, especially when you do a pull-up, the entire body weight is being carried through your acromioclavicular ligament. People, we don't realize about that. That is one of the most important ligaments in your upper body, especially in your shoulder. So we cannot name one particular ligament, Archana. So it depends upon the type of injury and the mode of injury and the mechanism of the injury.
The next question, please.
All right.
Next question is also from Archana, sir.
Yeah. What is the next question?
Yeah, discuss more about plantar aponeurosis and discuss the major muscles.
Okay. See, plantar aponeurosis is so important. That's what I've been telling you. Plantar aponeurosis is very important from the birth of a child. See, when we were born, every child, we do not have the arches. As we grow, as we start putting on weight, as we start walking, when we have a rocker bottom gait, usually child does not have an arch. When we have the rocker bottom gait, it slowly starts putting on the arches. The arches slowly grows. During that time, your plantar fascia is so important. And choosing a footwear is very, 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 very important for a physiotherapist, for us as well as for the patient. When when a physiotherapist says, I don't know how to choose a footwear, then we don't understand biomechanics. Biomechanics is the life of physiotherapist. I usually tell that, I usually have a statement, biomechanics is the nucleus of physiotherapy. So we will have to understand what type of footwear we'll have to wear in order to save your arch or save your plantar fascia. We will have to understand, we'll have to learn the anatomy and understand the biomechanics of your plantar fascia. It's not just a small structure, it is throughout your soul. So it depends upon how much you walk, how much you stand, how much is your body weight. Are you on the correct weight? If suppose you are 5.5 feet and you are 80-90 kilos, you're above your BMI. You're not maintaining your body weight, which is not only going to affect your internal organs and your cardiovascular system, it would definitely affect your foot, which will in turn damage all your other proximal joints also. So plantar fascia is so important, where you'll have to keep it very safe, do proper exercises, stretches, and as well as maintaining a good footwear. So that will keep your arches very good. When your arches are good, you will have, or we will have, a good stability. So plantar fascia plays a very important role in your stability. Unless or until you have a stable foot joint, you cannot move, you cannot expect a proper mobility. Suppose if I do not have a proper stable fascia, plantar fascia, the plantar fasciitis, the entire plantar aponeurosis, if it is not good for me, if it is not stable, I will not have a proper gait. If I don't have a proper gait, how can I run properly? How can I walk properly? How can I jump properly? I may run, but I cannot be a successful runner. Suppose I wanted to participate in 100 meters or a 400 meters relay, I cannot reach the target at an expected time because of my abnormal arch of the foot, because of my abnormal plantar aponeurosis. That would affect my gait, that would affect my entire muscles of my posterior aspect, because your triceps surae is affected, you're attached to the plantar aponeurosis. Your triceps surae would be tight enough. Your TA, your tender Achilles, will get into a tight, rigid structure. If your calf muscle is very tight, your calf muscle at your popliteal fossa goes and hugs. If you see the anatomy picture of your hamstring and your calf muscle, the place where it meets at the popliteal fossa, the calf muscle goes and hugs your hamstring muscles. If this is tight, your hamstring is also going to become tight. If your hamstrings are abnormally functioning, if that is becomes a rigid structure, your gluteus muscle is going to get into a problem. If your gluteus muscle gets into problem, you cannot have a perfect hip extensor. If you cannot have an hip extensor perfectly, you're not going to walk properly, you cannot run properly. So one small problem with your plantar fascia or your plantar aponeurosis is going to affect your entire gait. We can do all our activities of daily living, but that's not going to be biomechanically correct. Thanks for asking this question.
Yes, sir. Thank you, sir. And next question is from Ms. Yamuna Devi.
Okay.
How to define normal pronation and an abnormal pronation, sir?
Wonderful question. Thanks for asking this, Yamuna. This is where I told at the beginning of the session, we as a physiotherapy doctor, if we need to be successful, if we need to be skillful, we will simply have to understand biomechanics, learn anatomy. If you know anatomy and if you understand biomechanics, if you know which is normal, then you can identify which is abnormal. That is why I showed you few pictures of radiology. For example, the angle between the first ray and the second ray should be less than 9 degrees, and the calcaneum and the floor should be 20 degrees or less than 20 degrees. If it is more, your medial arch is high, you have a pes cavus. If it is less than 20 degrees, then it's going to be a flat foot. So you just have to have simple tricks or techniques to understand which is normal biomechanics. If we understand what is normal, then we can easily identify which is abnormal. And hope you remember at the initial first few slides I showed you, which is a normal. When you assess a patient, I told that we'll have to put the patient or make the patient stand in a posterior aspect, and we'll have to view from behind. View from the posterior aspect so that you can see the normal biomechanical axis of your ankle and foot. That's the way you assess it.
Yes, sir. Next question is from Ms. Nigel. Please, can you elaborate? Next question is from Nigel.
Yeah, go ahead.
Yeah. Please, can you elaborate on most common foot abnormalities in diabetes mellitus, sir?
That's a tricky question. Well, I would try to answer it. See, diabetes mellitus is a problem with your endocrine system that is not directly connected with your foot dysfunction. But yes, it could be indirectly connected. When a patient has a diabetes along with abnormal weight and leads a sedentary lifestyle, does not do any exercise, does not go for walking, and when he puts on abnormal weight, then there's a problem with the foot. Because the God has designed each and every structure in a proper way. He has the normal biomechanics. God has the normal biomechanics. He's designed it everything. See, if suppose I am 5.5 or 5.6 feet, I should have a weight less than 60. I cannot have 80, 90 kilos of weight. And if I have diabetes and if I'm leading a sedentary lifestyle, I don't do exercise, then my arches are going to slowly get dysfunction, or it's going to slowly get affected. In turn, it's again a connectivity, your plantar fascia, your entire posterior chain of muscles are going to get into trouble. So it is not directly connected with your foot mechanism. It can indirectly connect with diabetes.
Yes, sir. Thank you, sir. And next question is from Ms. Dr. Samira Parveen. Sir, please explain inversion of the foot, sir. Need to clarify on it.
Inversion is nothing. When your foot, your medial arch is more, or when you start walking with the lateral surface of your foot. Okay, a very simple assessment is put your foot into the water and take off, start walking on the floor. You can find out the marking, your foot marking. Check out which arch is more. If you find the medial arch is high, then you're going into an inversion walking. That's what I said. Make the patient stand, and the therapist should stand behind the patient, observe from the posterior aspect of the patient, and you can see the picture. You can have a very clear idea whether the patient has an inverted foot or an everted foot. If anybody starts walking on the lateral aspect of the foot, then it is an inverted foot. Then it means your lateral aspect of ligaments are into trouble, or it's more strained. They're giving more pressure on the lateral aspect.
Yes, sir. Next question is from Ms. Rishika.
Yeah.
Sir, can children below 5 to 10 years physically active have retrovalgus or retrovarus, or should we wait for a few more years to identify it?
I would personally say we can wait. Usually 10 to 5 to 10 years, children are in the growing phase. You can wait till 15, 20 also. You don't have to intervene into that. Meaning you don't have to very seriously do any surgeries, or you don't have to really intervene and do something for that. Maybe a small activity exercise. 5 to 10 years, they'll be in standard 5, 4. You don't have to intervene much. We can wait.
Yes, sir. Next question is from Ms. Nurul Afrin. What are the exercises examples in the biomechanics, sir?
Well, thank you so much for asking this question. See, I would say every physiotherapist is an expert, is skillful. So you are the boss for your patient. You will have to decide if it is an inversion injury, eversion injury, or if it's just a sprain, it's a problem with the talus, problem with the fascia, plantar fascia. You decide, you give the exercise. I cannot, that's what I said. Most of our people, most of our physiotherapy people, they have a set of exercises for everything. If it is an osteoarthritis knee, you give only quadriceps exercise. You don't think of anything else. If it's a PA shoulder, you just think of the shoulder wheel exercises, which has been there for past 50, 60 years. See, we should be more skillful. We call ourselves as doctors, we call ourselves as specialists. When can we become specialist? When we think out of the box. Think of your own ideas. Think of your own exercises. Think of which structure is affected. How can you stop it, or how can you prevent it? How can you reduce it? Think of that and give exercises. Don't have one set of exercises. If suppose Rupesh, take Dr. Rupesh, he is a sports physiotherapist. He deals with a lot of sports injuries. It does not necessarily mean that I have to follow all the exercise which Rupesh gives, or it is not necessary that Rupesh has to follow what exercise I give for my patient. He is skillful. He has learned his own biomechanics. He is the boss. He can give a different set of exercises, and I can design my own exercises. So it's all up to us. So think out of the box and give some exercises.
And it was good answer. Next question is from Ms. Soundarya. How to test biomechanics of medial collateral ligament?
Oh, Soundarya, thank you. And that's what we were discussing about all these while. See, medial collateral ligament, you just have to look into the anterior and posterior droid test and just do a small eversion. If the patient feels a pain, do a dorsiflexion with eversion. If the patient feels pain, yes, then it's a medial collateral ligament problem. Or do an anterior posterior droid test. Just like the other joints, it's just like shoulder, or how do you assess for an ACL in a knee joint? It's the same. See, I'll tell you people, we physiotherapists have to be proud enough because we are the only medical fraternity people who have so many numbers, enormous number of special tests. But unfortunately, we don't use it. We just have to start using all those things. We have so many numbers of special tests. We just have to use it at the right time. Do all special tests, all the possible tests, or do small motion. If you are not aware of, or if you're not so thinking of the special test, just do a small movement. If the patient says I have pain at that particular moment, then you just have to think what is the structure there. That's what I keep telling you again and again. Learn anatomy, understand biomechanics. If the patient says I have a pain during eversion, then it's something happening in the medial aspect. You just have to think what structure is there, why is it painful, and what is the pain grade. Think about that, give the exercise.
Yes, next is from Mr. Gokulakannan. How food dysfunction affects pelvic floor muscle?
Yeah, this is something very important for especially females, and as well as this is a huge topic, Dr. Gokulakannan. See, when there is a abnormal foot, when there is a dysfunction in your foot or ankle stability, you cannot have a proper stable position. You cannot have a stable gait, first of all. If your gait pattern is abnormal, or if you imagine both your feet are into an eversion position and you walk like this, that will affect the adductors of your hip. You try walking like that, that's going to affect your knee joint. It's going to in turn affect your hip stability and your hip mobility. That is where your pelvic floor muscles are. Your pelvic floor muscles, none of the females, most of the Indian females, I'm sorry, don't mistake me, we don't concentrate, or we don't even, when there is a female patient for us, we don't take time to concentrate on giving exercise or teaching exercise for pelvic floor dysfunction or pelvic floor abnormality. So that is where your pelvic floor gets into an abnormal posture or abnormal position, and that leads to various kinds of female related issues, including your PCOD, PCOS, pregnancy issues, a lot of other things are there. That's a huge topic. If you want me to talk, I can talk for a whole day about that.
And
It's a
we'll
continuation.
plan,
It's a chain of continuation.
we can plan for those sessions, sir.
Yeah.
The next question is from our YouTube viewer, Ms. Swarna. What is superincumbence, sir?
Superincumbent is nothing but the stability. It defines about the stability about a particular structure.
And yeah, next question is from Mr. Ashraful. What are common food problems in old?
Yeah, Dr. Ashraful, I would say that do not be closed. Be open. Be open. Think beyond the box. That's what I keep telling all our fellow people. Don't have a set of rules. Maybe like if I name 5 common problems, food problems in the older adult, you will have that only in mind. It's not like that. Think beyond the box. Don't have a set of exercises. Don't have a set of problems. It could be anything. See, somebody who walks with an abnormal foot, or somebody who has an antalgic gait, somebody who has a high stepping gait, who has a what is the other gait? I forgot. High stepping gait, antalgic gait, a different gait pattern. We always think about the hip or we think about the knee. It is not like that. It could be a food problem also. So older adult, again, it depends. Which, if you ask me what are the common problems for an older adult, I will ask you a question. Whom do you mean to be older adult? For me, somebody who is old is above 80. For me. And that is what ACSM says. The American College of Sports Medicine says people who are from 50 between 80 or 90, they are all called elderly people. They're not old. Who is above 80, 85 are called old people. In India, the situation is different. Even 50 years, you call them old. That's not the story. So how do you describe them old? And what is the daily activity of that particular patient? What are their ideals? What is the profession? What was he working as? And what is he doing now? We will have to go through all these assessments, and then you can conclude what his problem is. So every person can have a different problem. See, suppose if when I grow older, I become 70 years, I'll have a different problem. Dr. Chandramohan can have a different problem. Dr. Rupesh can have a different issue. Duna ma'am can have a different issue. Every one of us can have a different issue. Maybe Rupesh is working out every day. I may be a lazy guy, so I will have a different issue. Rupesh can have a different issue. So don't always fix on to what we read in our biomechanics book or what we have read in the college. That's all different. So now we have become practicing clinicians. We'll have to think out of the box.
Hello.
Yes, sir.
Are we running out of time?
Okay, no problem. We will take 1 or 2 questions.
Okay. And yeah. So next question is from.
Yeah, go ahead.
Yeah, please continue.
Next question is from Ms. Cyril Physio. Sir, if patient have foot drop, in that time we can use taping, sir. Is it helpful or not?
Who has asked the question?
Ms. Cyril.
Cyril.
Yeah.
Okay.
Yeah, Ms. Cyril from Mumbai.
Can we use taping? Yeah, definitely. Definitely, you can. What's wrong in it? Still, the patient has got muscle. Patient has got all his biomechanics over there. The foot drop is a problem which involves the neurological thing. The muscles are still there. You can use a dynamic tape. You can use a rigid tape also if you want. There's nothing wrong in it.
Next question, Rupesh.
Yeah, there are some questions here. What will you suggest to correct a pronated foot in children? Children below 5 years, I would not think of correcting them because they're in the growing phase. They're just 5 years. No, why do you want to correct them? When they start walking, jumping, running around, it will get corrected. A pronated foot would definitely get corrected. All you have to do is allow them to play. Don't do anything. A 5-year-old kid, what do you expect? Even if it's pronated, do not worry. When you allow them to play on the barefoot, it will get corrected. Okay, somebody called Nigel. Can you describe about the ideal footwear selection for foot? Okay, again, Nigel, thanks for asking this question. It again depends upon every person, height, weight, and what the profession is. Why are they going to wear the footwear? Suppose, see, Rupesh is a sports physiotherapist. He let's assume that he is playing every day for an hour in the ground. So he needs a sports footwear. I work in a hospital. I don't need a sports footwear. I need formal shoes or I need a sandal kind of thing. So it depends upon everybody's profession, everybody's nature of work and the tendency to work. Rupesh cannot wear a boot shoe and go and play in a ground. He needs more of a sports shoe, isn't it? So yeah, there are special assessments for sports shoes, purchasing a shoe and what type of shoe you need to buy. What are all the necessity things you need to verify before getting a shoe? Which is the best time to purchase a shoe? What should be the size? What should be the arch? What should be the flexibility? There are so many things in purchasing a shoe. That's a different class. If you want me to talk, I'll talk for half a day. So it's a huge thing in sports physiotherapy and biomechanics. So every physiotherapist needs to know about that. That's more important. Only then you can prescribe your patient. It's not just like asking your patient to go purchase a heel cushion or a silicone insole and asking. Those are all stupid ideas as far as I am concerned. See, naturally, you should ask the patient to get healed by himself. You cannot just substitute an insole, a silicone insole, or however costly it may be. That's not going to give, permanent relief. It's going to be temporary. As a physiotherapist, we'll have to do something permanent.
Okay, thank you. We will take one more last question. This is from YouTube and also I combine with the question with another participant. Both are similar actually. Sir, can kindly explain about what are the special tests used to assess the foot and any special tests for plantar fasciitis?
Sorry, sir. Special test for assessing?
Foot. And also is there any special test for plantar fasciitis?
Plantar fasciitis. Oh, yeah. Plantar fasciitis, it's very easy to assess. Patient would tell you about where the pain is. He would exactly tell you at the calcaneum or in between the head of the metatarsal and the anterior portion of the calcaneum. This is the place where usually a plantar fascia gets dysfunctioned or it gets injured. So it's very easy. You just have to put the ankle in a stabilized neutral position. Put it in a neutral stabilized position, hold the ankle and just try to stretch the foot, stretch the toes. Patient would feel pain. It's because your TA, your tender Achilles is being stabilized and only your plantar fascia is trying to stretch. When the patient feels pain, then it's a plantar fascia dysfunction. There are a lot of other special tests to do it also. To assess a foot, if you ask me about a special test or to assess the foot, what is the purpose of assessing the foot? Why do you want to assess? Again, don't have one set of assessments for foot. It depends upon what are you trying to assess. If it is a female who says that whenever I wear a heel, I have pain, and if there's another female who's young enough, or college going student who says I have pain only during jumping, or I have pain only during running, otherwise I'm fine, then that is the purpose of us to assess. And if it's an old gentleman, say about 60, 70 years, an Indian male who says that when I start walking, I have pain, but later on when I progress walking, I don't have pain. The pain is at the heel. Then you'll have to assess. So you have to think about which motion is affected. That's point number one. Which movement is affected? Point number one. Point number two, in which axis, which direction is affected? Whether the patient is not able to pronate, supinate, dorsiflex, plantarflex. Think about the motion, think about the axis. That's point number two. Then, which are the structures involved? If it's a muscle, tendon, ligament, or other soft tissues, if the fascia is tight, then go think about the joint and which joint is that. If it is a subtalar joint or a calcaneocuboid joint or interphalangeal joint or a metatarsal joint, think about that. Then you have to assess, treat, reassess. That's how you'll have to do. You don't have a particular set of special tests for generally food.
Thank you so much, Dr. Selvin, for a wonderful session and also politely answering almost all the questions due to time constraints. We are winding up now because we are having the next webinar starting by 8 o'clock. So we should get ready for that. So soon we will be having the topic. Biomechanics will affect pelvic floor, and I'm expecting you to announce the date soon, and we will be doing that.
Thank you.
I thank all the participants and my friends and Professor Tuna for their help to organize this session and also helping us to prepare for the certificate. Thank you all. We will be sending you the link. Just a second. I will be sending you the link.
Yeah, special thanks to all the participants for listening very politely. Thanks for being patient.
Yeah. So we will be sending the link for download too. And yes, thank you for all the participants. Take care. Good night and bye-bye.
Bye, sir.